Over to you, sir.
Yeah, thank you. Thank you very much, Dr. Mohanty Shenai, for those kind words of introduction. And this is a AID, Automated Insulin Delivery Symposium, where I will be speaking first on global outcomes, and then this will be followed by Dr. Benshi Sabu on the outcomes in our own country. So when we speak about, can I have the slides here? Yeah, okay, fine. So before I begin, let me have a brief introduction of the topic. You know that there are more than 5 automated delivery systems available globally. So what are these systems meant for? These systems are meant for increasing the dose of insulin or increasing the delivery of insulin when there is a hyperglycemia, and reducing the delivery of insulin when there is an impending hyperglycemia. And if there is a chance of a dangerous or a serious hyperglycemia, then the insulin delivery will be suspended, will be stopped. And if insulin delivery is suspended for some time, and when the glucose is back to normal, maybe after half an hour, or it could be even after 3 hours, then the delivery of insulin will be getting back. So it will be resumed. So this is in fact something we were dreaming for more than 100 years. You know, insulin has been discovered more than 100 years ago. And since the discovery of insulin, we were all apprehensive using insulin because insulin can produce hyperglycemia. And this hyperglycemia can result in arrhythmias, it can result in a stroke, and people can die of hyperglycemia. So we were ever since trying to automate delivery of insulin, and now for the last 2 to 3 years, we do have a system even in India, which many doctors are probably not aware, and this is 780G. So I am going to discuss on the glycemic outcomes with automated insulin delivery. So these are my disclosures. And this is a picture from the past. And this is from 2004. And this is our dear friend Adrian. And in 2004, I didn't have a hospital. And that time I was working in the government medical college. And this guy was trying to launch the Medtronic pump and CDMS in India. And if you carefully look at these 2 devices on my table, and these are sitting on my table, and this is the Medtronic insulin pump, and the other one is the CDMS Gold. Okay, so you can see the CDM as well as, and the CDM is the first CDM, and that is the CDMS Gold. And CDMS Gold we used for 2 years for research purposes. And we even had an oral presentation at the American Diabetes Association on few of our patients on how it is used for changing their lifestyles, and how we use the initial CDM for changing the dosages of insulin. And those were all type 2 patients. And managing diabetes, especially type 1 diabetes, and difficult to treat type 2 diabetes is extremely complex. It's extremely difficult, and multiple players are there. And I would say that there are more than 42 different factors which can influence the glucose levels. It is not diet and exercise alone. And this is how you can name all those devices over the years. In 2006, the sensor augmented pump was launched. In 2007, SAP was launched in India and was Paradigm 722. So sensor augmented pumps are those insulin pump devices which can integrate with the sensor. And from 2007 onwards, you might remember that the sensor will display the values on the insulin pump screen. And then the overnight closed loop. Then came the hybrid closed loop, and of late the HCL. HCL is advanced hybrid closed loop systems. And HCL are those systems where the basal delivery, so basal is not glargine or degludec. Basal in the insulin pump is same as the rapid acting insulin. And the basal delivery will keep on changing. So in response to the glucose levels from the continuous glucose monitor, it will change once in every 5 minutes. And the bolus, once the basal reaches the maximum, and still if the glucose is high, there will be automated delivery of the bolus. And this is how it has evolved over the years, over the last more than 30 years. And this is CDMS Gold that I have shown you. And this was officially launched in the year 1999 globally, but used only in research. And initial years, the pump and the glucose sensing devices were entirely different. So it was an independent pathway for each one of them. And eventually, in the year 2006, 2007 onwards, we can see that they have converged. And from the DIY community, from the Damiano family, there were even attempts at using both insulin and glucagon together in the insulin pump. And that used to be the bionic pancreas. And we'll be discussing in detail about all these in the twin technology talk tomorrow at 1 o'clock. And this is how we did in India. In India, we had the insulin pump from 2004 onwards, and in the initial years, it used to be all the refurbished pumps. They were not the new pumps. Those were the refurbished pumps which were imported, and these were used by the patients in the United States earlier. And this is the 2007 sensor augmented pump. You can see that the glucose is displayed in the insulin pump screen. And in 2022, we started using the automated insulin delivery. And that was a real transformation. I would say that it was a revolution. And it was a dream come in reality for the patients with type 1 diabetes and also for the doctors. And I am so sad to tell you that, to reveal the truth that doctors in many specialties even now, except the doctors sitting here attending the conventions and using yourselves, they are not aware of the fact that these devices which can automate the delivery is currently available in our country. And what is the recommendation? And this is a recommendation from the American Diabetes Association, the most recent recommendation in 2024. And what is the recommendation? The AED system should be offered for managing diabetes to youth and adults with type 1 diabetes. And preferably, for example, if somebody is diagnosed of type 1 diabetes at the age of 6 years or 7 years or 10 years, at the time of diagnosis itself, it should be offered. At the time of diagnosis, so that maximal benefits can be offered throughout the lifetime. And these are the currently available AED systems. You have the 780G, the only one available in our country. And we do have a couple more available in the US, Europe, and the rest of the world. Even in the United Arab Emirates, we have Tandem, you have the Omnipod 5. Among all these devices listed here, this is the only one AED which is a patch pump. So patch pump is a device where there are no infusion tubings, there are no strings attached. It is only the patch which will have, along with it, insulin. And these are more convenient. But if you compare with the other 4 devices, 780G has got the best algorithm. So the best algorithm with more people spend in range. So you know that now we are moving from an era of A1C to TIR, from glucose to time in range. And our ulterior objective is to have a time in range more than 70%. That is between 70 and 180 milligrams per deciliter, and a time below range, below 70, preferably less than 4% of the time. And 1% represents or corresponds to 15 minutes in a day. And this is a picture I obtained from Dr. Benshi some time back, and this is extremely useful. Look at the 5 modalities. One modality is not here. 5 modalities by which you can treat diabetes, especially type 1 or difficult to treat type 2 diabetes. One modality which is not there in the picture is using a glucometer along with multiple daily injections. And this is a commonly used one in our country. And the other modality which is probably acceptable and adopted by many in the rest of the world is multiple daily injections and then using a sensor. So we have a sensor over there and then multiple daily injections. Look at the time in range. It is only 54%. So 54% means you are treating them to failure, and almost all of them are going to develop complications and they will have a limited lifespan. And if you are using a sensor unintegrated pump, sensor and a pump separately, and that is what we used to in the earlier days. An insulin pump, of course, it has got some benefits of continuous subcutaneous insulin infusion, but when you are using it separate from a sensor, again, the TR is almost the same. It is only 55%. Whereas when you are using a sensor augmented pump, that is integrated device, then it increases to 63%. But still, it's below 70. You are not reaching the recommendations as per the international committee. So you have to reach more than 70% minimum. And then only the A1C will be less than 7. And that is possible only when you are using an automated insulin delivery device. And that is what we are trying to drive in. You require an automated insulin delivery device to reach a target of more than 70% TIR. And today I am going to discuss about this celebration, and this is the celebration from 780G from Europe, Middle East and Africa. And this is the data collected over 3 years of use of 780G in 100,000 patients. It's not a small number. And this is the clinical evidence because everything is available in the cloud. And look at less than 15 years versus more than 56 years and the TIR. And in all users put together, it is 72%. Very, very impressive data. And the time below range is 1.6, level 1. And level 2 hypoglycemia is 0.4%. Very, very acceptable numbers, exceeding the recommendations of the international panel. And this is with optimal settings. Again, it is exceeding all our expectations. And this is above the age of 56 years. It is more than even 80% time in range. And it appears as if with the new devices, we are able to overcome the biggest barrier, that is hypoglycemia. So hypoglycemia in the new era of using all these AIDs is actually not a concern. The only remaining concern will be, I would call it the residual risk will be the remaining area, that is hyperglycemia. But still, if you look at these numbers, this is first month of AID use, 780G, versus 12th month, that is over 1 year of use, there is absolutely no difference. It remains almost the same, which is almost 70 to 75% time within range and with no unacceptable time below the range. And these are the different countries representing Africa, Middle East, Europe and so on. And you can, Kuwait is listed over there, United Arab Emirates is there, so sufficient number, substantial number of people from India as well representing these numbers, and uniformly it is more than 70% time in range, and level 1 hypo below 70 is around 1.7, and level 2, and that is below 55, it is around 0.5%. So it is very, very acceptable, and this is country-wise again going through Europe and Africa, more than 70% time in range. And let me move on to a study, and this is comparing those who have no previous experience with a pump or a sensor, no previous experience compared against 780G, Minimed 780G. And this is the baseline, and this is SMPG, and this is the end of study. You can see that with glucose meters and multiple daily injections, it is still around only 60% time in range in type 1 diabetes. You are not reaching the target. Remember, our type 1 diabetes population, they have got a limited lifespan, and this is the reason. Whatever you do with SMPG or with sensors, it is very difficult or impossible to reach a target, but with 780G, it is 85% time in target. And this is what we are also experiencing. Dr. Benshi will be sharing the Indian data, and we do have a couple of publications as well from India where we have shown phenomenal benefits, and the patients in this new pathway, this is a new pathway of treating type 1 diabetes with automated insulin delivery, they will come back and tell you after 2 or 3 weeks, because it takes almost 1 month to get stabilized with the new system. It has got artificial intelligence, and it keeps on learning the person, the food habits, the exercise, the sleep and so on, and the algorithm adapts. So it takes at least a month to get adapted, and the results are phenomenal. And this is again the same, the ADAPT study, the advanced hybrid closed loop study in adult population with type 1 diabetes. This is an RCT comparing against one standard. So there is a popular standard, and that is without a pump, using injections, multiple daily injections, basal and bolus, and along with the flash glucose monitoring system, that is continuous glucose monitoring. And the subjects are randomized to either 780G or to multiple daily injections and intermittently scanned CGM over a period of 6 months. And look at the results. With continuous glucose monitoring, with a flash glucose monitoring system and multiple daily injections, the A1C has remained almost same. It is 9% at baseline. It is again 8.8% at 3 months, and almost the same A1C of around 9% at 6 months. Whereas with automated delivery, it has significantly dropped from 9 to around 7%. And this is a significant reduction in the hemoglobin A1C, and with improvements in multiple other parameters, including more number of participants reaching an A1C goal of less than 7%, and with no significant difference in the total daily dose of insulin. This is the diabetes treatment satisfaction. Let me tell you, any patient whom you are initiating on an automated delivery system, such as 780G, if you ask them after 2 or 3 weeks, they will tell you, this is the first time ever since the diagnosis of type 1 diabetes, my dear doctor, and this could be after 20 years or after 10 years, they would tell you that this is the first time after the diagnosis I am having a comfortable sleep at night, uninterrupted sleep at night. So it will completely transform the entire life of a person with diabetes. And this is the DTSQ, again showing positive results with 780G, and this is a hyperglycemia fear survey, and significant improvements in the diabetes quality of life. So can we use the system in type 2 diabetes? So we have been discussing about its use in type 1 diabetes. What about type 2 diabetes? We have at least 10% of our patients with type 2 diabetes not probably amenable to the newer therapies, whether you are using gliflozins or GLP-1 receptor agonists. Still the glucose is brittle. Within quotes, it is brittle. And this is one similar study, a pivotal trial. And this is A1C at baseline, and this is A1C at the end of 6 months. And this is when you have the optimal settings, because in the AD system, you have the basic settings and you have the optimal settings. So optimal settings are there when you are trying to change the threshold from 120 to 100, and when you are reducing the active insulin time to, say, for example, 2 hours, when you have the optimal settings and when you are very comfortable and confident about avoiding a hyperglycemia, then you may reach almost close to 80 or even 100% time in range. I know that Dr. Benshi and myself, we are having so many patients, because even yesterday Dr. Benshi has posted. Benshi, am I right? You have posted a picture in our group, 100% time in range. So because so many patients were consistently, they are having a TER of 100%. And can you imagine the A1C of those patients? A1C will be less than 5.7%. So they may not have any manifestations of diabetes despite being on insulin. And this is how we can use in a subgroup of patients where you may find it difficult for carb counting, because you have to have at least 10 to 20% of manual inputs despite the device being automatically controlled. And this is a group where you may have to have a flexible versus a meal estimation pattern. Instead of exactly counting the carbohydrate, still with 780G in the study phase as well as in the extension phase, in the flex versus the fixed pattern, there is an equivalent improvement in the time in range. It is still more than 70%. So this is the global experience. Dr. Benshi will be discussing the Indian experience. And in conclusion, the 780G, which can automate the delivery of insulin, along with the CGM and replacing the conventional insulin therapy, is benefiting those patients with type 1 and also the subgroup with type 2 diabetes. And as doctors, I believe that all the doctors treating diabetes should have the basic knowledge on how to advise and when to prescribe or recommend the automated insulin delivery systems. And doctors in all these specialties, I believe, the subspecialties attached to us, cardiologists, nephrologists, the neurologists, because when you advise a system, the patients might tend to have because they will go back to their family doctor or they will have an opinion from their cardiologist whether this is good or bad. So doctors in all these specialties should have a basic understanding of the systems which are available in India, the benefits, and of course the setbacks, because there should be some areas where it should be troubleshooted, because all the devices can also intermittently fail, and we should have the realistic expectations discussed with the patient. So let me also take this opportunity to announce the dates of JPEF 2025. And please block your dates on July 11, 12, and 13. So thank you very much for your patient hearing.
So shall we take the questions now or later? Okay, thank you, sir. So we'll